3/4 video. Ramsay Hunt syndrome, diagnosis and investigations, vestibular physician. Right, so when a patient walks into your clinic with an acute peripheral facial palsy and they've got that classic visible rash on the ear or palate, well, the diagnosis is clinical. It's pretty straightforward, right? But what happens when there are absolutely no vesicles to be found? That's what we're tackling today. The high-stakes challenge of catching the incomplete or completely rashless presentation of Ramsay Hunt syndrome. Because catching it early, it fundamentally changes how we approach facial palsy in the clinic. Here's the clinical diagnostic funnel we're going to walk through today. We'll start by catching that tricky rashless case, then look at virological confirmation, map out the audiovestibular deficit, cover exactly when to scan, distinguish the differentials, and finally wrap up with our key clinical takeaways. Let's dive right in.
Section 1. Catching the rashless case, also known as the zoster sine herpete challenge.
Get this, up to 1/3 of Ramsay Hunt syndrome cases actually lack a rash at presentation. Literally 1 in 3. The vesicles might show up days after the weakness starts, or honestly, they might never appear at all. So if you're relying solely on a visual clinical diagnosis, that's highly dangerous, and it frequently leads to missed therapeutic windows.
So you're examining the Hunt zone. You know, the pinna, the canal, tympanic membrane, palate, tongue, and you find 0 vesicles. You absolutely cannot just stop there and diagnose Bell's palsy. If your patient has severe otalgia, sensory neural hearing loss, tinnitus, or vertigo, and there's no visible rash, well, you are heading straight down the zoster sine herpes pathway.
Section 2. Virological confirmation, or as I like to call it, the saliva test.
Okay, listen closely to this. In a facial palsy with prominent vertigo or hearing loss, but no rash, send a Saliva VZV PCR. This right here is an absolute practice-changing clinical pearl. Detecting varicella zoster virus DNA via a really simple, non-invasive saliva test, it completely reclassifies the diagnosis to zoster sine herpete. And that is a massive shift because it fundamentally alters your treatment plan. It mandates antiviral therapy that a pure Bell's palsy patient simply wouldn't receive. Now, while saliva PCR is absolutely our practical, go-to non-invasive investigation, it's not the only tool in the shed. Obviously, if you do happen to have vesicles, you can just swab the fluid for PCR. But what if you suspect central nervous system involvement? Say the patient has meningiism, a disproportionate headache, or multifocal deficits. In that case, a cerebrospinal fluid PCR is necessary to check for VZV vasculopathy. And hey, if PCR is entirely unavailable wherever you are, parrot serology showing a 4-fold or greater IgG rise is your solid backup. But honestly, whenever possible, reach for that saliva swab.
Moving on to Section 3. Mapping the deficit, focusing on the audiovestibular assessment.
When you're looking at a pure tone audiogram for these patients, you're typically hunting for an ipsilateral sensory neural hearing loss, and it's often concentrated right there in the higher frequencies. Documenting this is absolutely essential right out of the gate. Why? Because you need to establish a clear baseline. It's crucial for counseling the patient on their prognosis and, of course, for tracking their audiological rehab over time. But we've got to look beyond the cochlea, right? We need comprehensive vestibular functional mapping. Now, caloric testing is great, it's helpful, but remember, it only assesses the horizontal canal and the superior vestibular nerve. This is where the video head impulse test, or vHIT, becomes absolutely vital. It interrogates all 6 semicircular canals individually. And it frequently reveals this broader, multi-canal pattern of vestibulo-ocular reflex loss that calorics alone are just going to completely miss. Then we add in cervical and ocular VEMPs to localize the specific saccular and utricular afferents that are affected. Put it all together, and you get a complete high-resolution topographic map of the lesion. I literally cannot emphasize this next point enough. Functional deficits can exist despite a normal-appearing 8th nerve on MRI. So test function, do not rely on imaging. Seriously, you must never omit functional vestibular testing just because the vestibulocochlear nerve looks absolutely pristine on a scan. The radiology doesn't always match the physiology, guys. The functional tests tell you what the patient is actually experiencing in the real world.
Section 4. Imaging and prognosis. Basically, one to actually scan. So how do we sequence this? We want to order investigations with a really pragmatic, targeted logic. You use the VZV PCR to confirm the etiology. You use pure tone audiometry to quantify any sensory neural hearing loss. You bring in the vHIT to assess reduced VOR gain. And then an MRI with gadolinium. That's used solely to exclude mimics. Having this clear purpose avoids both dangerous under-investigation and, honestly, wasteful over-investigation.
Let's actually expand on the role of that MRI for a second. It is generally not needed for your typical rash-positive cases. However, a gadolinium MRI becomes absolutely indispensable when the presentation is atypical, or maybe when recovery stalls out. We use it strictly to rule out structural or vascular mimics. Think of schwannoma, demyelination, or infiltration. Now, you might see enhancement of the 7th or 8th cranial nerves, especially at the geniculate ganglion. But remember, facial nerve enhancement alone isn't strictly necessary or sufficient to make the Ramsay Hunt diagnosis.
Just before we move on from testing, a really quick word on electroneuronography, or ENOG. If a patient presents with a complete facial palsy and their ENOG shows greater than 90% axonal degeneration within those first 2 weeks, that signals a pretty poor outlook for recovery. In some centers, that specific degree of early degeneration might even prompt a conversation about surgical decompression. So it's definitely an important prognostic tool in those really severe cases. All right, Section 5, distinguishing the mimics. Let's look at the differentials.
Without a doubt, the single most important differential here is Bell's palsy. Let's contrast the two. Bell's typically presents with mild or no pain, and it very rarely causes true vertigo or hearing loss. And critically, landmark trials show that steroids are super effective for Bell's, but acyclovir, it provides no real benefit. Zoster's sine herpete, on the other hand, comes with severe otalgia, prominent vertigo, and sensory neural hearing loss. Misdiagnosing occult zoster as Bell's palsy means you are missing that critical therapeutic window for early antivirals. You really have to actively hunt for those differentiating features.
But beyond Bell's, we have to consider a few other key mimics. A vestibular schwannoma, for instance, usually presents with progressive hearing loss and a much later onset of facial weakness. Acute otitis media or mastoiditis, you're going to see a bulging tympanic membrane, fever, and conductive loss. Lyme disease comes with that classic history of tick exposure and aretha migrans. But definitely pay close attention to central mimics, like an AICA or lateral pontine infarct. They can perfectly mimic the palsy and vertigo, but, and this is a big but, a central lower motor neuron palsy often reassuringly spares the forehead.
And finally, Section 6. Key takeaways and our next steps. Okay, here is your summary card for standardizing your practice. Number 1, always send a Saliva VZV PCR in any painful or audiovestibular facial palsy. Number 2, map the functional deficit meticulously with both vHIT and VEMP. And number 3, use imaging only to exclude mimics, not to diagnose the syndrome itself. If you just integrate these 3 core steps into your daily practice, you are going to confidently catch that tricky rashless presentation and get your patients the right care so much faster.
In Video 4, Management and Prognosis, we will cover the 72-hour window, supportive care, and the zoster vaccine. But before we wrap up today, just ask yourself, how many atypical Bell's palsy patients in your past practice might have actually been hiding a rashless zoster? Thank you for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.